Hi, I'm Dr. John McAllister. I'm going to discuss knee arthroscopy. Everything that you watch on this video is also available on our website at St. Peter's Bone and Joint Surgery. The knee arthroscopy is really probably the hallmark minimally invasive operation, and I'm happy to say in orthopedics we've been pioneers of trying to operate through smaller incisions and do more in a less invasive manner. This is nothing new, and in fact I started doing arthroscopic surgery in about 1985. It was going on for 10 or 15 years before that. One of the things that happened, fortunately for me, is we use a fiber optic lens to look inside the joint. We use a light source that illuminates things, and then we have a nice little, very small, high-definition camera now that is able to take an area about this big in the knee and put it on a TV screen like that. So when I'm looking at the kneecap on the undersurface, if you could imagine with the magnification, the kneecap's about this big. So it gives you an idea of what we can do with the technology. So what we typically are looking at is either cleaning up surfaces, removing loose bodies, things from the knee, trimming meniscus cartilages that are torn, resurfacing bone in small areas if there's a defect. We can also repair or put stitches in cartilage. There's a lot of things that we can do arthroscopically now, and in fact most operations about the knee other than joint replacements we do arthroscopically because we can see better. When you actually open the knee and try to look in there, it's sometimes difficult to get good lighting. So the arthroscopic surgeries have really taken over knee surgery. Arthroscopic surgery may be the most common operation done in the United States today. This typically is done through a couple of small incisions. So this is a knee, this is the kneecap, and we're basically trying to work around the kneecap. And we have a camera that we'll put in through a small incision that lets us look in the knee, and then we make another incision on the other side that has instruments, little tools that we can use to trim or repair, put stitches in, that sort of thing. So I'm basically working through two small incisions and watching what's going on a video screen. If you have a torn meniscus, which is very common, there'll be typically tears in the back. Sometimes we stitch those, put actual sutures in, and more often we just trim out the piece that's torn. The cartilage doesn't have a very good ability to heal, so only certain tears can be actually sewn and repaired with any hope of them actually healing. I do repair the meniscus when I can. Again, for most adults, we're talking about removing the part that's torn. The part that's torn is not working anyway. If there's a damage to the surfaces of the joint here, I can smooth that down. I can actually scrape away a little bit of whatever cartilage is left and drill holes in the bone, and that may stimulate some new surface to grow over. Or sometimes we can even remove or transplant a plug of bone and cartilage from an area that doesn't get much stress on it and move it into a weight-bearing area. So there's a lot of opportunities to reconstruct or rework the joint surface. Obviously, as you do more invasive things, the recovery tends to be a bit slower. If we're talking about just trimming a meniscus, most people can be up within a day or two on it, getting busy once again. I like you to stay home, put ice on the knee for the first 2 or 3 days so it doesn't swell. If you can do that and basically rest it, then most people get better very rapidly. The amount of swelling you get is going to determine how comfortable you are, say at 3 days or a week or 10 days. Most people just walk back into the office with a couple stitches in their knee, a couple Band-Aids over the stitches at about 10 days to get the stitches out. We go over the pictures. We talk about what activities are acceptable now. We talk about returning to work. It's possible to go back to work for a lot of people with a more sedentary job even within 3 days or so. You do typically need an anesthetic, a general anesthetic, for about 20 to 30 minutes. I typically have you take an aspirin as a blood thinner for a couple of weeks. Just to decrease the risk of a blood clot. The risk of infection from arthroscopic surgery is about 1 in 500, so it's quite unusual, and hopefully it won't happen to you. I always think that's a very unlucky card if you get an infection after arthroscopic knee surgery. So if you have more questions, we should be able to discuss that further in the office.